All right, guys, we're gonna get started with conference today. We have residents here in the room at university, and I see that Dr. Albert has joined us on Zoom, and then we also have Dr. Connors here in person. So we have a couple of experts that are definitely going to help us with some learning points with this case. It is a difficult one today. It's going to be a diagnosis case, so we'll focus on that. And for the residents in the room and on Zoom, you know, Amelia and I have been doing our 20 questions, and so today, if we want to go through a more real-life clinical reasoning, we can. So here, if instead of asking a full HPI, you want to think about labs or vitals right away, feel free to do that. And we'll sort of pause at a few intervals and see what our differential looks like. The case was just here at the university, so if you know what it is, please try and let the other people figure it out first. All right, let's get started. So I gave you some information already. This is a 37-year-old man who was sent to the ED from his primary care clinic when the resident physician noted that he had new periorbital and leg edema. And so I'll leave it up to all of you to ask me more questions, type it in the chat, whatever you want to do.
So what brought him in?
Bilateral.
Okay, so a couple questions. So what brought him in to the PCP, and then was the edema bilateral? So the patient says that starting in about January of this year, he had been feeling more fatigued, and then he did notice some of the swelling, and so he sort of went in for like a routine annual flash talking about these problems visit. And then, yes, the swelling is bilateral on the eyes and the legs.
What's his creatinine?
A great question. So, yeah, Dr. Kusari wants to know what the creatinine is right off the bat. So she's already started to think about her differential. So, Ariana, why don't you tell us what you're thinking about, and we'll go from there.
Like a nephrotic syndrome?
Yeah. And specifically, why did nephrotic syndrome come to your mind as opposed to something like congestive heart failure?
Because of the periorbital edema.
Yeah, because of the periorbital edema. And, you know, this is a topic that we've discussed before in the location of the edema. And I know Dr. Albert had a good way of teaching us about this. Dr. Albert, would you mind just going through that again and how you think about the different edema that occurs in nephrotic syndrome versus congestive?
Sure. It's customarily taught that the edema results from low albumin with spilling of protein in the urine, but that's actually not the case unless the albumin is exceedingly low, like around 1, maybe 1.5. By far, the most common cause of the edema is a hydrostatic edema because of increase in intravascular volume because of problems with renal perfusion. And so intravascular pressure is high, causing the edema. The other point to be made is that if you refresh your minds on the Starling equation, you'll remember that that the effect of protein is related to the difference between the interstitial protein and the intravascular protein, or the intravascular versus extravascular. And because of sigma, the permeability coefficient of the membrane of the vessel to protein, protein can move across the vessel. And in the steady state, a fall in intravascular protein will be matched by a fall in the interstitial or extravascular protein, so that the transmural protein difference won't change. And accordingly, there won't be edema because of a protein gradient. In an acute setting, when you infuse a couple liters of saline and markedly reduce the intravascular protein, without time for the extravascular protein to change, then you'll have the protein gradient, osmotic gradient contributing to edema. But that doesn't happen in the nephrotic syndrome unless the protein is extremely low, like around 1 or 1.5, albumin 1.5.
Perfect. Thanks, Dr. Albert. So I re-reviewed the Starling law of fluid flux across membranes and read exactly what Dr. Albert just described. They even did experiments where they, with plasma pheresis, slowly took off extracellular proteins in patients, and ultimately these patients did not have edema because, as Dr. Albert just explained, proteins really tend to equal out between the interstitium and the intravascular space, and so the oncotic pressure, unless your protein level is really extremely low, will equilibrate and is not a major cause of edema in most cases. So in nephrotic syndrome, forget that it's a result of the low protein, and it's really a result of increased intravascular volume because your RAS aldosterone system is so jacked up. Okay. Great, so Dr. Casari, I'll tell you the creatinine was 0.97.
That was his baseline or his new one?
That's his current creatinine. His baseline is around 0.6.
Can we get a UA with it too?
Absolutely, the UA is completely normal. No blood, no protein. Great. Okay, what else would you all like to know?
What other symptoms? Is there any other complications, things like fatigue, any other weight gain, especially palpitations, vision change, stuff like that?
Yeah, so he does say the reason he came to the PCP was because of his fatigue, so he has been feeling that.
You can get a TSH too.
Yeah, and I'll specifically answer the questions that you asked. So Schwab, you asked, so no weight gain. You asked visual changes, no visual changes. What else did you ask?
I don't remember, just the flu symptoms, palpitations, I think was another one.
No.
Palpitations.
There, I'll only answer what you guys asked me very exactly. No free.
So another question, actually, what medications is she on?
Great. This patient takes no medications at all.
I'm not sure.
Is it this patient?
What is she?
Oh.
And Sneha, as we do this, do you mind building out the differential with the questions that they're asking?
Absolutely,
Just
yeah.
so we don't get too sloppy, start going,
Yeah.
butt test.
Yeah, and so that's what, I always prompt you guys to tell me why you're asking the questions, but if you want to tell us why you're asking, what differential you're thinking about, that'd be great.
Yeah, absolutely. So for the other stuff about computational, nicotine is one, or just hypothyroidism in general. And then for medication related stuff, periodism, like edema, stuff like inhibitors, angioedema, probably as well. So that's what I was.
Any bowel changes?
Any bowel changes? Yeah, he's been constipated.
Any unintentional weight loss?
No.
Any melena?
No melena. So why would the melena matter in this case?
I guess like melena or metathesia, if you have like colorectal cancer, you can get like nephrotic syndrome secondary to that.
Sure, so maybe you're thinking patient might have cancer and so has a paraneoplastic syndrome that causes nephrotic syndrome, okay? That's rare. And then in the comments, we also have, so not only hypothyroidism, but hyperthyroidism with with a level of new heart failure can also cause swelling. But we've sort of already cornered ourselves into thinking, hey, heart failure related edema tends to present differently. So that's a little bit lower on my differential for this person specifically. Okay.
Any muscle weakness or easy bruising?
Okay, what are you thinking with that?
Like any other endocrine kind of processes?
Yeah, other endocrine processes, so muscle weakness, bruises.
Like a Cushing?
No bruises. And really, other than the fatigue, like no localized muscle weakness.
Does he have any prior history of surgeries?
Great question. Why are you asking?
Like lymphedema, so it could be some type of like thoracic outlet, thing, or, you know,
Yeah.
if you had what's that crazy card surgery the kids have all the time? Not all the time, it's really rare. Extremely rare.
Like a Fontan?
Yeah, that can be a classic cause of lymphedema.
He has had no surgeries. But that's great to think about, hey, I'm gonna broaden my differential for all kinds of edema, and typically we think of edema in 4 ways, right? We think, is it localized or is it systemic, and then, or widespread, or is it pitting or non-pitting? And some of the non-pitting causes you've already mentioned, which include hypothyroidism or mixed edema, which is a deposition of something and not just fluid related. And then lymphedema, of course, also, it's traditionally non-pitting.
Any nail changes?
Why do you ask that?
There's that really obscure yellow nail syndrome, which also causes lymphedema, causes generalized conjunctivitis.
No nail changes. Dr. Hershey, since you were mentioning lymphedema, does this pattern seem usual to you for lymphedema?
I mean, the periorbital stuff, to me, I don't really know about to say one way or the other, but I would classically associate that, but this isn't a classical case already, so.
Yeah, that's fair.
I wouldn't disagree.
I think, like, you know, super traditionally, we do think of it as more being localized in the extremities. And it would be odd for a person to have lymphedema syndromes that present so far away from, so like just the eyes and just the legs, but not the arms, right? So, again, a little bit less likely in this case. So we haven't done an exam yet here, and we don't know the nature of the edema.
And also say some of these things that, like Jake's asking, these are gonna be hard questions for your patient to answer. You know, I mean, it's good to ask, hey, have you noticed anything on your skin or your nails? But that plus the examination is gonna be, you know, they're not gonna notice, say, Terry's nails. That's a very subtle thing. It's not gonna pop out there.
Yeah. And then the other thing we've also been emphasizing with our conferences is getting away from these broad questions of, hey, what past medical history does this patient have? Because I know what you're asking, but when you ask that to a patient, they won't know what you're looking for. So you really have to ask them specifically, have you ever had a heart attack? Hey, have you ever had surgery in your belly if you're worried about somebody with adhesions or et cetera, right? So be very specific in the questions you ask your patients and use as many lay terms as possible. And so do the same thing here, although I can infer a little bit about what you're asking. Okay, where do you guys want to go next?
Anything in his family history, like autoimmune diseases?
Yeah, so his father has Hep C, and his mother has Hashimoto's. And so, Ariana, since you asked, does that change how you're thinking about this patient, knowing that family history?
Well, I was kind of trying to tease out, like, if he had any risk for, like any types of, like, cirrhosis or causes of cirrhosis, if that was another etiology of this.
Yep.
Or something else would be like, thinking about other, like, cardiac causes, like amyloid, but that necessarily wouldn't be, like, inherited.
Yeah, usually acquired, okay.
Like an infiltrative kind of disease or like sarcoid or something like that.
Yeah. And some of these, you know, infiltrative, and I also put inflammatory in it. Inflammatory diseases, particularly as Dr. Albert was mentioning, will increase capillary permeability and can cause edema. But that's not something we think about super classically. Okay. I think we have a good start for this differential. Do you guys want to, and I think I heard you wanted a TSH as well, just to sort of knock that off pretty fast. Yeah, so his TSH is 6.14.
So the free T4.
Yeah, and so Dr. Mahal, why do you ask for a free T4 here?
Sometimes there's like a euthyroid 6 syndrome that you can get where the TSH is elevated, but the free T4 is within normal limits, so it just helps to kind of confirm what the pathology is.
Yes, great point. So for any patient that you think is acutely ill or in the hospital, getting just a TSH is sometimes not helpful because patients can have a euthyroid 6 syndrome where their thyroid looks abnormal, but their free T4 is normal. And so here, his free T4 was 0.65, which is low.
I'm really sorry if this is Dr. I can't see it. I heard the UA was normal, but that would only be albumin. Did we also get a protein creatinine?
Yes, Dr. Herner is asking, hey, the UA was normal, but sometimes, you know, if it's not enough proteinuria, maybe you won't see it there. And so the urine protein creatinine, also normal.
I think Jonathan's got a question up there in the chat about expanding on the social history, any known infectious diseases in the past.
Yeah, Jonathan, I like that. So for this patient, his social history is he's a never smoker, he only drinks socially, no drug use, and he's had these tests before, and they've all been negative. So, okay, let's have, second years in the room. Targa is here. Targa, tell us where the case is so far with a brief summary, and if there's anything that's bothering you about it, anything that seems, you know, to not fit with the rest of the story. What are you thinking right now?
So you're asking for like a summary statement?
Yes.
Okay. So, say like a 37-year-old male with no past medical history, presenting from his PCP's office with new periorbital and leg edema for an unknown length of time, with labs concerning for hypothyroidism.
That's great. Okay. So Targa basically said this 37-year-old man with periorbital leg edema that's new with labs that suggest hypothyroidism. Okay, so that's where we are now. Are you feeling comfortable getting him on some levothyroxine and sending him home?
Not a trick question. I feel like no, he's a new conference. So.
He's a new conference, so no.
Triage.
Okay, all right, that's fair.
Triage teaching.
And I don't think we've seen a pattern yet that's not sicky thyroid, right? So to have a little bit of an elevated TSH, a little bit of a low free T4, you know, is this a thyroid that's appropriately turned off because he's ill? The thyroid saying, hey, we need to calm down for a second, or is this the driving cause? And those numbers are pretty, as you probably suspected, pretty unimpressive.
Right.
Yeah.
Yeah. Okay, so I'll give you guys a hint here.
I'm sorry, wait, before we do hint,
Okay.
can we just characterize the chief complaint? I feel like we're asking these we didn't ask like how long this is going on for, has he ever had this before? I hate to like sound like a sort of third-year med student, but we need to like go through all those things. Right?
Yeah, we have lots of third-year med students in the room.
Great, even better.
Okay.
No sense in reinventing wheels, we just ask all the usual questions.
Yeah, I think sometimes we forget that because I think we harp home so much about, hey, let's do clinical reasoning in real life, but it also includes asking the right questions in the HPX. Let me see what Dr. Chan has to
We're all
say.
in the mindset of 20 questions.
I know.
You can only ask.
You switch back and forth because we talk to you all the time.
So to answer Dr. Chan's question here, anything unique happened a few months ago? So the most unique thing that's happened to him is that he's had intentional weight loss, and over 18 months, he's lost 250 pounds. No viral syndrome, no travel, none of that. Okay.
When was the onset of this? So when exactly did this first start for him that he noticed?
Yeah, so So what he tells you then is that his weight loss journey started in sort of middle of 2019, and through 2020, and through it he felt great. It was through the wellness center, medically supervised, and he's an electrical engineer, so he decided to just continue it on his own, except he stopped feeling super great in January of 2021, which is when the fatigue started. And then slowly over that time to March, he started to notice this edema. So it's been about like a 2-month process.
Got it. Great. And at that 2-month point, December, January, sort of getting at what Dr. Chan's asking, did anything unusual happen at that time? Did he have another major dietary change? Did he start a supplement regimen? Did he travel anywhere at that time? Any of those things? So
no to all of those. So he has never taken any supplements that aid his weight loss, no medications to aid his weight loss. He has not traveled, and nothing else major has happened.
So how did he lose the weight? What is his weight loss regimen? Did he do nutrition, exercise?
Great. So his weight loss regimen really included minimal exercise. And he was doing it through the wellness program, but now he started walking a mile a day. And then he's on a 1,000 kcal restriction diet.
So just to clarify, he lost 250 pounds?
Yes, Dr. Chan, since mid-2019, he's lost 250 pounds.
Wow.
And he's
What did he
currently on
put
a
out?
1,000. Yeah.
What was his weight at the beginning, I guess?
Yeah, he was around like 350, or sorry, like 400-ish when he started.
So he started.
I don't know, that's like putting some red flags for me because regardless of what you do, 250 pounds to be lost just for caloric restrictions is nearly impossible. But for me, it's kind of pointing towards like there's something else going on that's causing him to lose a significant amount of weight that he just hasn't noticed. It may be something that's been going on for a while, but there are some issues with that.
Okay. And then John also asked, does his diet include animal products? That's a great question. So I'll clarify that for you. He does this 1,000 kcal with mushrooms, bell peppers, apples, and 4 cans of tuna.
Oh my gosh.
That's like my
Throughout the day, he'll sort of eat that
It'd
and
be like pureed vegetables.
That big.
Does he take a multivitamin? No, he really does not take anything in addition to his diet right now. No meds, no supplements.
Okay.
Well, I kind of want to know more about his vitals and exam then, to see how it looks. Like, is it weight loss and weird distribution?
Yeah, so just would like to look at his vitals and exam to see if we're noticing anything that the patient isn't telling us. Okay, so the vitals are here for you. Pretty normal. That's sort of his blood pressure, and it remained so throughout the hospitalization. And I'll tell you guys that his BMI calculates out to 220 right now. He's a pretty tall guy. And his exam, honestly, other than him being sort of a thinner guy with loose skin as a result of his weight loss, was fairly unremarkable. Is there anything specific you want to know about it?
What's his edema, sitting or not?
Yeah, great. I forgot to tell you that. It is non-sitting.
Isn't there any skin rashes or oral ulcers or anything to suggest like vitamin and mineral deficiency?
Yeah, so at this point, he does not have any skin rashes or oral ulcers or, tongue discoloration that would suggest vitamin deficiencies, is what Dr. Hunter asked.
Do you have any evidence of like muscle loss or like you having difficulty walking, anything like that?
No, gait is fine. I mean, he appears somewhat cachectic, but his muscle tone is okay.
What's the, like, depth of the edema, is it like 2+, 3+, is it seeping?
Well, it's hard for you to tell the depth because it's non-pitting, and so you really only do the depth when it pits, right?
Is it seeping, I guess?
It's not weeping, and it feels sort of nodulary, firm kind of edema, localized more anteriorly on his legs.
What about periorbital edema? Can you characterize that?
The periorbital edema is more in the dependent regions, it appears, although it truly is periorbital, and again, it's like slightly firm to touch.
Is there a disproportionate amount to either the abdomen or the extremities? I kind of did remember like Korsakoff having, is it like the puffy hand or is it the puffy belly?
Like kwashiorkor?
That's what I'm thinking.
Oh, yeah. Kwashiorkor with deficiency. Yeah, he doesn't have like a giant belly or anything like that.
No big puffy hands.
No big puffy hands. Nope.
No evidence of neuropathy, numbness, neuro changes.
No neuropathy. And then I think
Basically neurologist after a week.
Yeah.
Yeah.
Any questions?
MRI, please.
Our residents want an MRI, which is not indicated. So I think, and along the same lines of sort of neuropathy, Dr. Albert asked, tuna has mercury in it, is this mercury toxicity? And I'll say, no, it isn't, Dr. Albert, I'll tell you guys. And then Dr. Chan asked, was he eating store-bought mushrooms? Yes, he was. Dr. Chan, why do you ask that?
I guess if he was mushroom hunting, he could have maybe chronic mushroom poisoning causing liver toxicity, causing edema.
Yeah, I think Danny did a recent case where somebody had psilocybin toxicity from eating mushrooms and some electrolyte abnormalities. But if we're thinking of specifically Amanita phalloides, that mushroom is not native to Colorado, just to let everybody know. So we don't really see that toxicity here that often. But also, yeah, they were store-bought mushrooms and safe to eat. This isn't mushroom poisoning either. But Dr. Chan, has made some clutch points for you guys. He discovered this weight loss, and he also asked about liver toxicity. So I'm going to give you some more labs here so we can move this along. His BMP, really most notable is that his sodium is low, but otherwise it was okay. I'll let you guys read it as I type it.
We'll say it's a little unusual, Sneha, if that really has been his entire diet for over a year. I mean, that is missing some essential nutrients. I know we've not noted that he's had skin changes or ones that are obvious to us, but whether that's true or not true, he almost has to be deficient in some things with that diet.
I feel like, Amelia, you did a case about a woman who had a lot of weight loss after her bariatric surgery and then had like progressive NASH cirrhosis after that. I don't know if this fits that kind of picture at all.
Okay.
That was what it reminded me of.
The weight loss associated NASH cirrhosis.
Yeah.
We don't, yeah, exactly. We don't totally know the mechanism, but yeah, he's got
Your goal actually like kind of double sword there.
yeah.
Okay, so this is what I've given you guys so far. Anything jump out?
That was AST and ALT.
Yeah, Dr. Bowman says AST and ALT are very high. Okay. I can give you more labs now if you want, but I would love to hear what you all are thinking now.
Dr. Chan, that's exactly what I'm saying.
Natalie.
Only an apple. I think it's albumin surprising.
Is albumin surprising?
I would
Yeah.
expect it to be low with that diet. I guess the tuna.
Tuna, let's go.
I'm eating a lot of protein.
Loaded enough. I would like to see what the mercury level is.
Mercury level, I don't think was checked.
Cover.
The albumin is interesting. If you talk to Dr. Mailer at Denver Health, and I'm sure Dr. Albert has heard him say this before, is that he runs the weight loss clinic there and was the chief medicine there for a while, is that to lower your albumin requires some dietary deficiency but needs to have inflammation as well. And that the patients who have anorexia and bulimia, those conditions, if they're not inflamed, they actually have albumins of 4 right until they have a fatal arrhythmia or something else like that. So it's very highly preserved in the body.
Yeah, the critical issue here is that you will never see patients as cachectic as some of the ones that Naylor admits to Denver Health with anorexia. Some of these people, their body weight is, 60, 70 pounds, things like that. And they are not low on albumin. You have to have cachexin around, which is TNF, in order to break down albumin. So dietary deficiency, with the exception of pellagra, I believe, is the only way you're going to get low albumin because of dietary problems.
Great.
CBC.
A CBC, yeah, great. So CBC was actually normal.
Does he have an intestinal parasite?
Does he have an intestinal parasite?
In the review system.
We're gonna need to check for that.
An O&P.
Yeah, what do you think about a little group work for just a minute?
Yeah.
Kick it out there. I think I feel like we're a little stuck here.
Yeah.
Maybe a quiet discussion of what's going on.
Okay, so Dr. Connors would like a quiet discussion of what's going on.
Groups of 2 or 3,
Yeah.
a minute.
I think that sounds good.
Yeah, come back with a little differential.
Yeah, okay. A minute, we'll do quiet reflection. Maybe the people on Zoom can quietly reflect in the chat what they think might be going on.
Sorry, I just felt like they were going to start to be passively.
The hard case.
What's that, picmonic?
Dr. Johnson, tell us what you Dr.
We were just like we're at the point where it's just like a lot of things going in different directions. So kind of like trying to like take a step back, and like the chief insult is this weight loss. One thing we were talking about is like, okay, is this all weight? Like his diet is crazy. So like it could be just from the diet. Are we missing something else? Do we do a lymph node exam in like this younger gentleman? And then we were also talking about like hepatocellular liver injury can be caused by rapid weight loss as well. I've never seen it really in the thousands. So like, I don't know if that's it, but it also sticks out to me that the hepatocellular injuries in the thousands.
Mm-hmm. Okay. Schweib or Ariana, any input from your group that was different?
Yeah, I mean, our biggest thought is like, our initial concern is like, from the history, the biggest concern is some sort of nutritional deficiency. Something that's missing, but we don't know exactly what. And then trying to link that with the liver injury pattern, because that's like the most remarkable lab finding. And so we were just talking a little bit about what causes LFTs in the thousands. And so infections such as viral hepatitis, medications he's not on any, potentially some sort of toxin that we're just not aware of. And then we were trying to go down the pathway of, is there a nutritional deficiency that causes liver injury? And we are stuck at that part. So we would probably refer to our good friend Up to Date on this one, or the liver tox list that everyone keeps talking about.
Great. Yeah, so I think that some excellent input from our residents, which is that we want to take a step back because things are going in such different directions. We had this thyroid problem, but now this huge liver injury has shown up. And to answer Dr. Chan's question, mental status is okay, so we're not worried about acute liver failure just yet here. And so we've talked about this before in one of my previous lectures. And so causes of acute liver injury, acute liver failure, think about it systematically. The number one thing you're going to do is go to liver toxin, make sure it's not medication. So in this case, the resident who saw these labs, of course, day one, because the ED obtained that for him, ordered an aspirin at APAP level, which were negative, and he's on no meds or supplements, so it's not meds. Then you're going to think about viruses, right? Another big cause for LFTs in the thousands. And so you're going to get some things on day one and some things you're going to put on the back burner. We got a lot of labs for this patient up front. His HIV was negative, acute hep panel was negative, his EBV and CMV, which resulted a few days later, were also negative, so not that. You're going to get imaging, right? Because some imaging findings can cause acute liver injury that's pretty dramatic. And so Budd-Chiari is one thing. So the resident got a liver ultrasound with Dopplers, and there was no Budd-Chiari and no other clots present. You have to think about ischemic hepatitis, but we haven't obtained a lactate, which I'll tell you was normal on this patient. And he hasn't had any episodes of like fainting, no hypotension, and so there really no causes for him to have ischemic hepatitis. And then infiltration by tumor, which you'll also see on imaging. This patient also actually got a CT scan of his belly, which showed normal looking liver parenchyma. And then you're gonna, once you rule some of these things out, day 1s and 2s, you're gonna start thinking about autoimmune. And so hepatology was consulted, and some of the autoimmune labs were also negative. And then finally, you're going to think about toxins and miscellaneous, right? So we talked about the mushroom, which isn't native to Colorado. You're going to think about Wilson's and hemochromatosis. And so you can send in ceruloplasmin as at least your first test. In this patient, if anything, it was elevated, so less likely, but he also got a 24-hour copper, which was normal. And his ferritin was mildly elevated at 1,500, but again, no like obvious signs of deposition on any of the imaging. Okay.
Let me just comment on Amanita phalloides. It's an acute fulminant liver failure. It's not a chronic disease. I've seen a couple.
Okay. Thanks, Dr. Albert.
Can I ask a question about the ferritin? Because we kind of give a picture of him as being not inflamed, like I believe these are not expressive in the albumin, looking good in the non-inflammatory setting. To have a ferritin that's so high, and I doubt he's eating tons of iron with his diet. So is that like an acute phase reaction that we're seeing elevated in that ferritin? Not really inflamed?
It was a mystery in this patient as to why his ferritin was elevated. Hepatology was also pretty confused by it, and so they did send in genetic testing for hemochromatosis, which is what one would do in this case if you were worried, which all came back normal. And so thinking more sort of acute phasey, unclear. Yeah, it did normalize now, so we'll sort of see what happens. Okay. And Jonathan's still hung up on his diet. I mean, like Shah mentioned it too, he's worried about the diet too and whether this is a nutritional deficiency. I think that's completely reasonable here.
And just to verify one more time, he is not taking any type of supplement, no like collagen supplement, no vitamin B12, no multivitamins. Because I know there's one medication that can kind of interfere with your TSH assays. So he's not taking anything, no over-the-counters.
No, he's not taking it, and just to be sure, I'll give you the level. It was greater than 1,200, so it was normal. And his folate was normal too, which is a mystery also. But
if you go to like the same grocery store that buys vegetables from the same place that are all covered in the same preservative, that's
It's not a preservative issue, it's not, it's not that. Okay,
Sort of think cofactors here a little bit.
cofactors, okay, so let's take a step back. I think taking a step back was a good thing to do here. Let me see what Dr. Chan says before I go on my thing. High transaminases is normal billy with rays, other toxicity, mitochondria.
Nobody likes the tuna,
Everyone is hating on the tuna. Okay, all good thoughts there, Dr. Chan. But what else? So like, you guys are stuck, I'm stuck. We can ask for help, right? From people who are more of an expert in certain systems than we are as generalists. So, do you want to call anybody for help?
Do we get hepatology?
Say yes.
liver team.
Yes. We got a HEP consult, and I'll tell you what the HEP consult says. They basically were like, get all these labs. We want to make sure this isn't like a crazy acute liver injury problem, and that this patient isn't going to tip over into acute liver failure, and then we'll come back. Is there anyone else you want to call?
I actually want to call endocrine too.
Endocrine. Yeah, so that's what they did here. And Schwab, why do you want to call endocrine?
I mean, first of all, I'm stuck. Second of all, you know, that thyroid stuff again is one like abnormality that we have to fully explain. And
Maybe
it also
he has
like
the hyponatremia.
yeah, he has like multi-system issues, and when I think of that, I'm thinking, is it autoimmune or is it some sort of hormone issue going on with endocrine? Doesn't really fit with like the autoimmune given the low inflammatory marker, so endocrine would be my next kind of, hey.
Yeah, absolutely. And we've seen these in a few conferences before where I think we often miss the endocrine system as a cause of these like multi-system problems. And then Dr. Albert also commented here, he's still wondering, could this all still be due to the hypothyroidism? So endocrine gets called and they come in and they are like looking at these labs and are saying, well, you know what, this TSH isn't high enough for how low the free T4 is. So we're worried there might be a central problem. So they go back and they talk to the patient. And he also says, hey, by the way, I have had no nocturnal erections, and his libido is really low. So with that information, our resident, who did an amazing job, our team just were so killer here, got some more labs, and so the FSH and LH were low. Testosterone was low. It was only like 8, and the lower limit of normal is like 150, so extremely low. Okay, so now what are you thinking?
Like causes of central pan-hypopit.
Causes of central pan-hypopit. Can you think of in what kind of people we see presentations like this?
Postpartum.
Postpartum,
She
yeah.
has drastic weight loss and huge fluid shifts in that setting.
Yeah, that setting.
Creative or tumor.
Yes, and then, what about like younger women? Why would you?
Anorexia.
Yeah, exactly. So we know that, inadequate caloric intake, and low fat deposits will cause this sort of central pan-hypopit, in which sometimes we see as a manifestation in young women who become amenorrhagic. One of those words. Okay, so does anybody want to throw a guess as to the final diagnosis here? Because this is all the information our consultants needed to tell you the answer.
Something hypo something.
Something hypo something.
Pituitary secondary to more PO intake.
Yeah, so this was all, and Thomas, I'm sad, is not in the room right now, but he got it. He mentioned this. This was all starvation hepatitis. But what's been in my slide? So hepatology was basically when they heard this story in conjunction with endocrinology, who heard the story and saw a central pan-hypopit, said this is all related to starvation. And so in this patient who was under a medically supervised weight loss program, decided to sort of continue this very stringent caloric restriction on his own, and then added on a little bit of exercise, ended up having just a severe calorie and carb deficit. So ultimately what happens when we enter this phase, and all the data that is here is in patients who have anorexia, and that's really the population that's been studied. Once the liver sort of runs out of options on glycogen stores and has no supplies for gluconeogenesis, it will go into an autophagocytic state where it starts using the amino acids that are present in the liver cells to help supply energy to the rest of the body. And so this autophagocytic state in the hepatocytes is what leads to this liver injury. Some other mechanisms that have been suggested are also an additional oxidative state just from like being in this chronic state of malnutrition. So there's likely some mitochondrial problem that's going on within the liver itself with the oxidative stress. And then just so you know, in this patient that was admitted to the hospital with this starvation hepatitis, once we started feeding him, his liver enzymes actually got worse, and so they peaked at 4,000 for the ALT and about 3,000 for the AST, so extremely high liver numbers. But that's known to be a side effect of refeeding as well. And so little is known about that specific mechanism, but just beware that refeeding can cause worsening liver injury before it gets better. This patient also had refeeding in the sense that his phos was like hanging out around 1, so make sure that you're, in any patient that you're concerned about refeeding, that you're looking at their phos levels and repleting aggressively. Because pop quiz, what's the worst thing that can happen with, respiratory decline, right? Your diaphragm will stop working and you'll have respiratory arrest. So that's not what we want to happen. And then repleting potassium as well is important. And then all of this for this patient got better when his caloric intake got better. And so he was just seen at his PCP's clinic again. His liver enzymes have nearly normalized. He feels a lot better. They did start him on levothyroxine for right now, but they're planning on just checking the TSH and following his function to see if some of the thyroid problem just sort of resolves on its own once his caloric intake and pan-hypopic gets better. They currently are not planning on doing testosterone replacement. They want to just see what happens with caloric intake. And then just the last thing to mention here, patients like him and patients who have anorexia nervosa, once they are in the weight restoration process, they actually can sadly have a NAFLD picture. And so currently his ALT is in the 100s, and so they're hoping that does normalize in the future. But sometimes these patients do sort of, ironically end up in a NAFLD state when they start to gain weight again, because the liver's just been so starved.
Is this more of an issue with like the very, very rapid loss of weight, or could you see a lot in like the acute service in Denver Health with patients who have just been starving themselves for a long period of time?
It can be both. So, like I said, most of this is studied in patients who have that sort of chronic extreme malnutrition and whose BMIs are, in the 10 to 15 range. Not many case reports of this happening. I did read one where it was a 45-year-old man who was on a weight loss program and lost just like 20 pounds over a couple months, and he presented like this. His liver function tests weren't as bad as our patients were, but I think it can happen even with like fairly rapid acute weight loss if you're not keeping up with your essentially carb intake, which your liver needs to help supply energy to the rest of the body.
Which is fascinating. You don't see it as much with bariatric surgery, right? Is that because it's more regimented, more nutritional support? I'm just kind of curious.
Yeah.
It's not seen as much.
I don't know the answer to that.
And you were also saying, like, is this the standard weight loss diet? Because there are no carbohydrates. Like, there's like that, that diet probably has like 10 grams of carbohydrates a day in it or something. So I wonder if that's what's actually used as the diet in the weight loss clinic or something else.
Yeah, I'm not sure how much in touch with the clinic he was.
I think you have to get down below a healthy weight for these things. I'm not sure if, I think the weight loss patient's going from 500 or 600 pounds to 300 pounds. I think there's still so much free fatty acids and things like that, but I don't know that that's gonna allow this to happen. I think it might be that this person
Yeah.
got under 150 pounds, or the anorexic patients who are.
I think it's, yeah, you're right, Dr. Connor, it's about the fat stores in the body, because you still have those fatty acids, but once you run out of the fatty acids, you gotta go to the amino acids
Yeah, that's
for energy.
I still have some concerns about this diagnosis. Again, from the experience with the anorexia nervosa patients at Denver Health. As I recall, hepatitis is not a common, in fact, might even be a rare presenting complication. And again, those patients have the most severe starvation, if you will, of any that you'll ever see. You know, I also wonder how you can separate the effects of starvation in this instance from the effects of on the pituitary with hypothyroidism, which by itself is known to cause hepatitis, moderate elevation of AST and ALT. I don't know how you can make a distinction between those two processes, particularly in this case, but I'd have to go back and check, but starvation hepatitis, I think, is extremely uncommon in the anorexia patients.
Maybe a combo.
And even less so, I think, in patients who don't have anorexia.
Yeah, Rick, I think you're right. I don't know if there's a second hit here, you know, whether it has to be a different diagnosis or just why does some fraction of the anorexics get this particular side effect? I don't know. I agree.
I don't either.
Or-
Let me look it up.
Those are separate than this liver process.
Yeah.
I don't know.
Dr. Chanda, for the patients that do end up getting liver biopsies, in this case, I think the biggest thing you see is these like autophagocytic cells that the pathologist can see on the slide, but that's pretty common to see. This patient, hepatology felt, did not require a biopsy, so we don't have tissue for him.
Cool, okay.
It's a great
Yeah.
case. Yeah.
Yeah, I know this is, you know, exceedingly rare. We don't see this population, but I just think this one was worth sharing with you all because I thought it was pretty neat.
Importance of doing a review systems